I just want to sort of give a talk that ties in the talk you just heard in through femoral neck fractures and just dabble on intertrochs, which will then slide us right into the proximal femur talk by Eric Johnson, so to bridge the two concepts. This is a talk that I typically give for board review courses. So it's the principles are coming right out of the OKU and Miller Review. I'm just highlighting the stuff you need to know for your test for the OKU, for the residents, and to pass your boards for the PG5. That's sort of right where I want this talk to be, in that area. So let's talk about hip dislocations just for a second. And remembering, we just learned here, the blood supply to the femoral head is the medial femoral circumflex artery, which forms an extracapsular ring with the lateral femoral circumflex artery. And it's good to sort of look at this image because you have to remember the blood supply to the femoral head is truly retrograde. And so when disrupted, that's a problem from an AVN perspective. It's truly, for displaced femoral neck fractures and for some hip dislocations, a vascular insult to the femoral head. These are the ascending arteries. You see them coming up through the neck, perforating the capsule. And this gets into this issue of you're asking yourself, for hip fractures, is it an intracapsular fracture or an extracapsular fracture? We get calls from the residents sometimes, say, we got a femoral neck fracture. I'm thinking, okay, well, old patient will book it for a hemi, and I go in and I see it's an extracapsular sort of fracture right at the intertrochanteric line, likely well vascularized, so we just switch it to a fixation. So I sort of ask myself that question, is the fracture for femoral necks intracapsular or extracapsulars? Back to hip dislocation, though. It's a vascular insult potentially. It can result in AVN and subsequent post-traumatic hip arthritis. So for posterior hip dislocations are typically posterior. 90% of dislocations go out the back. Typically a dashboard injury, head-on collision. Up comes the dashboard, takes the hip straight back. They're in a seated position with the hip at 90 degrees, and out it goes. That's typically what we're going to see. Treatment is emergent closed reduction. So what does that mean? Well, I mean, that can mean a lot of things. Is that for 6 hours, 24 hours? It depends. Sometimes they call you at 3 in the morning and you don't want to get out of bed and get in there and get to the OR. In our practice, I would advise you that this is a closed reduction for a posterior hip dislocation in the operating room under general anesthesia with the patient asleep and relaxed. Why? Well, if you have the PG2 or PG3 that's on call trying to pull this relocated in the trauma bay, typically now more and more of the ER physicians aren't sedating the patients. They're worried about some sort of complication will come back on them medical legally. So we have less opportunity to sedate, at least in our institution, in the ER. And if you're trying to pull on this and the patient's spasming in pain, you're just dragging the femoral head across the posterior hip and skiving the cartilage. So if you want to, it's easier for you to get it reduced. I would submit to you, you come in for this injury and you relocate it in the operating room under general anesthesia for posterior hip dislocations. And if you can't get it closed, you open it up through posterior approach, Coker-Langenbeck. The nerve at risk, the sciatic nerve, typically happens at the time of injury. Think of the force it takes, 1/2 mb squared, or mass times acceleration, the actual force to break the posterior wall and or dislocate the hip. It's significant, and that force doesn't just stop when a hip ball goes past the socket. It boing, goes right into that sciatic nerve, not atypically. So that's in about 20% of patients you're going to find an associated sciatic nerve injury with a posterior dislocation. The AVN rate's about 10% for hip dislocations posteriorly, and 15% of these patients, if they've had a dislocation, you can say is going to go on to arthritis. That's important to know because if you sort of have these numbers firm in your mind, not just for the test, but you start talking to the patient's family straight away, day one, saying, you got about a 10% to 50% of AVN versus hip arthritis, so we're going to watch for that. And they won't be asking, well, how did that happen down the line? Just bridging quickly on femoral head fractures, we had a nice talk by Dr. Teffelman. Just to repeat, type 1, 2, 3, and 4. 1s are below the fovea, 2s are above the foveas, 3 have an associated femoral head and femoral neck fracture, and the 4 is an associated femoral head and acetabular fracture. Most classifications aren't worth anything. They're just some doctor trying to be famous, get their name on a classification. But if a classification helps you make decisions in the middle of the night, or otherwise, and as prognostic, those two things, decision-making and prognostic, it's a good classification. So Gastillo would be a good classification. I think the Pipkin classification is a really not unreasonable classification because it helps me make decisions, and it is prognostic. And that's why we're going to spend some time on it, and you will see it on your test in the OIT and the boards. so you should memorize it. So basically, the treatment's based on fragment size, location, displacement, hip stability. And quickly, type 1, those are infrafoveal. You can treat them non-surgically. There it is, unless there's a small displaced fragment. See those little joint mice in there? You say, well, I wouldn't treat this surgically, but there's other little fragments, and you got to do an arthrotomy, get those out of there. And only for the infrafoveals, if it's a large displaced fragment, you have to treat it surgically. Most you can treat them non-surgically. Type 2s are superfoveal. They all got to go to the OR. Make them right. Anatomic reduction, stable fixation. Type 3s, associated femoral neck and femoral head fracture, all need to be treated surgically, open reduction, terminal fixation in patients that are young. What's young? Under 65 for your literature and for your test. If they're older patients with this bad injury, do an arthroplasty. And finally, the 4s are treated surgically, typically through a posterior approach. So now on to femoral neck fractures. Again, classifications. Do you need to know the Powell's classification? I think so, because it helps me make decisions in surgery. So the 1, you're looking at the angle of the fracture line relative to the horizontal. So look at 1 up there. It's a 30-degree angle. This is arbitrary. Powell said, well, we're going to say 30, 50, and 70 degrees. And you don't have to necessarily measure that out and memorize that, but you just think the higher the angle of the fracture, the more unstable it is if you're going to do an ORIF, and the greater risk that the fracture is going to displace if the patient non-compliantly weight bears. That's sort of how to think about the Powell's classification. Is it a high slip angle, sort of? The type 3s are more horizontal relative to the horizontal. And then we all know the Garden classification. I won't spend much time on that. So how do you treat femoral neck fractures? Well, if they're non-displaced, that'd be like a Garden 1 or 2, a valgus impacted, or truly a type 2, which is just sort of fractured, not in valgus, but undisplaced. Not common, but you'll see that. The treatment's the same regardless of age. 3 cannulated screws typically. We'll talk about the Powell's 3, which is a little different, but typically it's going to be 3 cannulated screws. Okay? And there they are. Now, ideal screw configuration. We hear all about this, and should you spend all this time and energy and radiation for you going in and out with your guide wire, making sure the screws are in this perfect, ideal, inverted triangle position? I think it probably depends on your time, energy, inclination, and patience, but I would submit to you it's worth the time. Screw position for femoral neck fractures is important mechanically. So let's get into that. It's the idea of cortical support, the endosteal support of the screws within the endosteum and the cortex of the femoral neck. So here's a case study. When I was at St. Francis Hospital as a PGY2, the surgeons there back in 90, 91, were using Knowles pins. And it doesn't matter if you're using Knowles pins or cannulated screws, but you see here, there's a patient, 80-year-old female, let's say, obese, slightly demented, on prednisone for years, osteoporotic, just gave up cigarettes, 2-pack-a-day smoker, Camels, unfiltered, the worst host. And they don't listen to what we say, even if they wanted to. Please stay non-weight bearing until this fracture heals, we would ask them. They want to stay non-weight bearing sometimes, but mostly it's like, I'm 80, I do what I want, and they're going to walk on it. So I assume everything I fix they're going to walk on. And if they're all clustered, you see the screws in the middle, and you don't have a screw on the endosteum, what happens? Well, let's take a look at it. At 10 days, do you see how the screw... I don't have a good angle on this. It's not shooting. But look at the one on your right. The screws have found, they've found the endosteum. And this fracture's gone into some varus and collapse. On the AP radiograph and posteriorly, the fracture has flexed and displaced posteriorly as the screws find the cortex, as they should mechanically when the patient weight bears. It's the idea of cortical support. Here you have a screw that's not along the endosteum inferiorly, and as the patient weight bears, and it's not on the endosteum posteriorly. It's getting there, but it's not. As they stand, the screw finds the internal endosteum and displaces, typically. Can we avoid that? Perhaps with appropriate screw fixation. So this is what we're shooting for. It's an inverted triangle, and you see the screws are just sort of scattered towards the periphery, and it's likely more stable, particularly in the parodic patient. And see that inferior screw? I would even scoot that a little more posterior. The ideal screw is inferior, caudal, and posterior. That's sort of the most important screw, particularly for these comminuted fractures. Typically, they're comminuted more posteriorly on the femoral neck. That's a trouble zone. And so there it is, that ideal screw. You see, that's a nice placed screw. You can see it's inferior, it's caudal, and then it's posterior. So femoral neck fractures, that was the undisplaced. You treat them all the same, screws. What if they're displaced? Well, in young patients, the literature is going to define that as 65. It's not my number, but that's the number you're going to go with on your test. You want to perform an ORIF. Make it anatomic if you can, and stabilize it. And in young patients, timing is urgent. There's lower rates of AVN when treated early. That's his femoral neck fractures now. And anatomic and a reduction of internal fixation, stable fixation is what we want. Slight valgus is acceptable because they may stand on it, but thou shalt not varus. Okay? Varus reductions are avoided. And typically these are done through, for femoral neck fractures, I like to do it through an anterior approach. You can use a Smith-Pete or a Hoyter approach, the same approach we use for anterior total hip. It's a nice approach to the front of the joint and spares the vasculature. And outcomes, the most important thing is quality of reduction and stable fixation. You want an anatomic reduction or slightly valgus. Here's the one where you maybe add one more screw or fixation device. Remember the Powell's 3 high slip angle? They're the ones that want to slide. So in those cases, you may add an additional screw. You see that trying to go across the fracture line at 90 degrees. And or you might want to add, in some cases you can add a 2-hole DHS. But see, this is the problem child, the high slip angle. Beware of that one. It wants to slide down. And so this is not illegal. You could use also a supplementary DHS, 1 or 2 holes ideal, but usually I just add a 4 screw. And older patients, what do you do for femoral neck fractures? Well, there's not a lot of debate actually in the literature on this and for your test. Although, you know, how we define older, we all have patients that are 75 and 80 and spry and playing golf and pedaling their Peloton trainer, all that sort of stuff. And so you may treat them a little differently, and we'll get to that in a sec. But in general, for your test, older patients with displaced femoral neck fractures get an arthroplasty. Why? Because you want to get them up and get them moving and not keep non-weight bearing, avoid a bed sore, pulmonary complications, thromboembolic complications. But the failure rate, let's say you say, well, I want to fix. Dean Lorch used to come here, God bless Dean Lorch, and say, I fix everybody. I don't care how old they are. And that's an approach, but he was an expert surgeon, and he was pushing the envelope and publishing on that sort of technique. But the fact of the matter is that out there in everyone else's hands, that if you try to stabilize elderly patients with fixation rather than endoprothesis, you have a failure rate of 40% for the reasons I just discussed, the patient that I discussed earlier, the parodic bone, and they're oftentimes well-meaning but non-compliant. So should you use a unipolar hemiarthroplasty, if you're going to do arthroplasty, a bipolar hemiarthroplasty, cemented, uncemented? What do? You got all these options out there. Well, the answer is it doesn't matter. But that's the answer for your test. You can do all those things and be just fine. It's how you do it. It's your technique that you pay attention to. So there's no difference in morbidity, mortality, or functional outcome on any of those techniques. But I would submit to you that for the active patient, think about total hip arthroplasty. We're sort of trending that way. When I was training, the indication for a total hip arthroplasty for a displaced femoral neck fracture in an old patient was if they had ipsilateral hip arthritis. And now, you know, for just my active patients that are really get up and going, I do a total hip on them now. And thank you for your time.